Good day, LU4 students. I am Dr. Cecil Jimeno, and the topic that I will discuss is antifungals. The macroscopic fungi such as mushrooms, puffballs, and even those that we see available in grocery stores represent only a small fraction of the diversity of the kingdom fungi. The molds, for example, are a large group of microscopic organisms. And here, looking under the microscope, you can see the broad variety of their structure, and don't they look very beautiful? However, the study of antifungals is very important because in recent years, human fungal infections have increased dramatically in incidence and severity. We're getting so good in the things that we do in medicine. We're able to give now better chemotherapy agents in critical care. Those who would have died are being resuscitated. But at the cost actually of being prone to various kinds of infections, including those from systemic fungal infections. The increased use of broad-spectrum antimicrobials, which would eliminate even the good bacteria and would make us more prone to secondary infections. And even the HIV epidemic have been some of the reasons for the dramatic increase in incidence and severity of fungal infections. Thankfully, most of the fungal infections are minor irritations that happen in the skin and mucous membrane. They itch a lot, they're unsightly. And this local or superficial mycosis are thankfully quite easy to treat, even if they do have a tendency to be recurrent. It is people who are immunodeficient, such as those who are post-chemotherapy, those who have conditions such as HIV epidemic or such as HIV/AIDS, who are more prone to developing systemic or deep mycosis. So just take, for example, aspergillosis, which can occur as an infection with pneumonia that could spread to the heart, to the lungs, to the other parts of the lungs, to the brain, and even the kidneys via the bloodstream. And apologize to those who are eating a child, an infant with mucormycosis. I'm not sure exactly why the child is immunocompromised, but you can see how severe would be the infection on the facial area, the eye, and even in the brain. And even for this tinea barbae, this mycosis on the area of the beard and the mustache can be secondarily infected and can look very unsightly. And so antifungals will work for these different fungal infections. The antifungals can be classified according to use as to the type of infection that you're dealing with. You can give antifungals as systemic drugs, whether given oral or parenteral, for systemic infections. Or you can also give them systemically as oral drugs, even for mucocutaneous infections that have failed to respond to topical drugs. And then we can give the antifungals as topical drugs for mucocutaneous infections. Now, according to structure, there are different types of antifungals as enumerated. The polyenes, the azoles, of which there are two types, the imidazoles and the triazoles, the antimetabolites, the allylamines, the morpholins, and the echinocandins. So these are the main types of antifungals. Show you the outline of the discussion, whether we talk about the polyenes, the azole, the antimetabolites, the echinocandins, the allylamines, and the morpholins, and the other drugs that are not listed. We will first give a brief introduction, probably the structure of the drug, the mechanism of action, their kinetics, their clinical use, and adverse effects and drug interactions. If just to give you an overview of the topic, these are the drugs acting on fungi. You have drugs that alter the cell membrane permeability, and you have drugs that work on the cell wall and block the beta-glucan synthesis. You have drugs that are anti-metabolites that block the nucleic acid synthesis. And you have those that disrupt the microtubule functions, preventing cell mitosis. And these are the drugs that use these different mechanisms of action. And so shown on this slide is the basic structure of a fungal cell to illustrate to you the mechanism of action of certain antifungals. So the fungal cell is made up of the cell wall and also the plasma membrane. This plasma membrane is the structure, is made up of ergosterol, and the cell wall is made up of chitin, certain proteins, as well as the beta-glucans. Now, the action of the different antifungals would be to break down the cell membrane by integrating into it and creating pores that actually allow the entry, for example, of fluids. Take note that both the cell wall as well as the plasma membrane actually provide the fungal cell wall its shape and its form and protects against mechanical injury, preventing osmotic lysis, and providing the passive protection against the ingress of potentially harmful macromolecules. So if you then fail to produce the ergosterol that makes up the cell membrane, or if you create pores here in the cell membrane, you may allow the entry of fluids and cause osmotic lysis or introduces mechanical injury. Now, the action can also be in the nucleus, through drugs like 5-fluocytosine or 5-fluorocytosine that interrupt the DNA and RNA synthesis. So shown here graphically are the different mechanisms of action of the antifungals. So again, the ones that act on the nucleus to impede DNA and RNA synthesis. Those that act on the cell wall, such as the echinocandins that inhibit the beta-glucan synthase, so that there is a failure to produce these beta-glucans that form part of the integrity of the cell wall. Or the polyeins like amphotericin B and nystatin, these drugs they become incorporated in the cell membrane and introduce pores that weaken the cell membrane, allowing for osmotic lysis. Or this set of drugs, from the terbinafine, to the morpholins and the azoles that impede one or more of the steps that are involved in the production of the ergosterol that forms the cell membrane. So we'll talk about first these drugs that form the pores, the polyeins. And these comprise the drugs ampho-B, nystatin, and natamycin. So for me to remember them, I think about polyein. Instead of in, I say polyein, so that I remember that the polyein is made up of ampho-B, nystatin, and natamycin. So they're the ones that interact with the sterols in the cell membrane, whether it's the ergosterol in the fungi or the cholesterol in humans, to form pores or channels through which small molecules may leak from the inside of the fungal cell to the outside. So think of pores or poles, that are inside the cell membrane, and these are the polyions, no? So amphoby, nystatin, and natamycin. Next, we go to the azoles, and it's easy for you to remember the azoles because they all end in azole. And later on, you'll learn that there are two types of azoles, no? The imidazoles and the triazoles. And where they work is that they inhibit the cytochrome P450 dependent enzymes involved in the synthesis of ergosterol, which is required, again, like I said, for fungal cell membrane structure and function. So if you take the production of the ergosterol, the action of the azoles is actually downstream, no, in the last step towards the formation of ergosterol. And that higher than that, no, you have the morpholins, no, from squalene to lanosterol, and the allylamines from squalene to squalene 2,3 oxide. So azole, morpholin, allylamine, AMA, no? They inhibit the formation of ergosterol. Go to the antimetabolites that act as inhibitors of both RNA and DNA synthesis via the intracytoplasmic conversion of 5-fluocytosine to 5-fluouracil, and the echinocandins that inhibit the synthesis of the beta-glucan, resulting into the disruption of the fungal cell wall and cell death. So fluocytosine and echinocandins. And finally, the allylamines and morpholins, like I said, these are the allylamines here, the first step from squalene to squalene epoxide, and morpholin from squalene to lanosterol. So just to show you again, the AMA. So azoles are the last step. Morpholin is from squalene to lanosterol, and allylamine is the interferes with the action of the squalene monooxygenase. So moving on, like I told you, how we will talk about these drugs is first how they're used, no? So systemic antifungals for systemic infection, oral drugs or systemic drugs for mucocutaneous infections that are not responsive to topical drugs or that are still mucocutaneous but are more disseminated, so that you'd rather use systemic antifungals. And finally, we'll talk about the drugs used as topical agents. And so for the systemic antifungal drugs for systemic infections, these are the main drugs that are used, no? The polyions, the azoles, the antimetabolites, and the echinocandins. So these are the drugs that we'll talk about. And we'll begin with the polyions. That will be amphotericin B, nystatin, and natamycin. So you notice that in this slide, nystatin and natamycin, although they're considered to be polyions, no, are in parentheses because nystatin and natamycin, although once they were also used systemically, for the most part, they are now only used as topical agents because of toxicity. So in fact, when we talk about the polyions as for systemic use, we're only talking about amphotericin B. And polyions are named that way because the polyin means that they contain many double bonds. And the polyin macrolide implies that there are large lactone rings of 12 or more atoms. And the prime examples of the polyions are ampho-B and ampho-A, which are antifungal antibiotics that are produced by Streptomyces nodosus. And of the two, ampho-A and B, it is only ampho-B that is in clinical use. So just to show you double bonds of the polyions and the macrolide, no, that is found, no, in this polyenes. And again, the polyenes are polyans, amphoby, nystatin, and natamycin, otherwise called pimarazine, but only amphoby is used systemically. So again, the mechanism of action, we've already talked about this. Polyenes, no, they form poles or pores that interact with the sterols to form, they interact with sterols in cell membranes to form channels through which then allows the cell to become leaky, allowing the leakage of intracellular ions like potassium and magnesium, and even macromolecules, eventually leading to cell death. So just to show you that graphically, if this is the cell membrane that's made up of ergosterol, the polyenes become integrated into the cell membrane, introducing these spores, no, which allow the exit of essential ions as well as macromolecules. The polyenes have a selective fungicidal effect. They exploit the differences in the lipid composition of fungal and mammalian cell membrane. And so in fact, ergosterol is the cell membrane sterol found in the fungi, whereas you know that the dominant sterol of bacteria and even human cells is cholesterol. And that's why there's some selectivity to its action. No? The polyene, especially its prototype, amphotericin B, is very important because it's active against most systemic fungi. So if you forget everything I say in this lecture and you need to guess, no, given a systemic fungal infection, what you want to give, amphotericin B is typically the drug of choice because it has the broadest spectrum of activity against most of the medically important molds and yeast. So it's the mainstay for the treatment of life-threatening systemic fungal infections and most other mycosis, except, of course, possibly the dermatophytes. So look at the spectrum of its antifungal activity. It's active against most of the clinically significant yeasts, such as Candida and Crypto, even Histoplasma and Blastomycosis. It's also active against the pathogenic mold Aspergillus fumigatus and Mucormycosis. And therefore, it's useful for nearly all life-threatening systemic mycotic infections. The downside, though, with amphotericin B is its toxicity, and so many recently discovered newer antifungal agents have replaced it for many disease conditions. However, amphotericin B continues to be used as the initial induction regimen for serious fungal infections, meaning, like I said, you cannot think of what to give and you suspect a systemic fungal infection. You can give amphotericin first, and then afterwards, you replace it by one of the newer azoles for chronic therapy or prevention of relapse. Also, the empiric therapy in selected patients in whom the risk of leaving a systemic fungal infection untreated are high, meaning for prophylaxis. For example, you have a cancer patient, you've given them chemotherapy, so they develop neutropenia, your white count is very low, and then they develop fever, and you've given broad-spectrum antibiotics, but they failed to respond. They're still febrile. You suspect systemic fungal infection, maybe candidemia, no, candidiasis. And so what you can give as empiric therapy for prophylaxis is amphotericin B. It can given for topical use such as mycotic corneal ulcers and keratitis as topical drops or direct subconjunctival injection, in fungal arthritis directly into the joint, and for candida in the bladder, no, you can give this through direct bladder irrigation, and this route has been shown to produce no significant systemic toxicity. However, these are mostly for historic highlights. You can still do that. Actually, we hardly use ampho-B anymore for these indications because there are other drugs, no, that can be given. So again, amphotericin B as an example of the polyenes, as the sole polyene for systemic fungal infections, is very important because among the different antifungals, it has the broadest spectrum of activity, whether you give it for aspergillosis, cryptococcus, like in cryptococcal meningitis, for blasto or coccidiomycosis, or even for candidiasis, even for candida, let's say in the bladder, like I said, you can give it. And so, again, very broad spectrum of activity. However, despite no, there is some toxicity to it, and resistance also develops. Although it is quite specific for the fungal sterol, there is still some binding to the human membrane sterol, and this may account for some of the drug's prominent toxicity. Resistance also occurs if ergosterol binding is impaired, either by decreasing the membrane concentration of ergosterol or modifying the sterol target molecule to reduce its affinity for the drug. No? So in fact, the fungi can evolve, no? So that there might be some resistance to the agent. It is not absorbed from the gut. Once it is given typically systemically per IV, for example, or even intrathecal, no? After it is given, more than 90% is bound by serum proteins, and it's mostly metabolized, but some amount is excreted unchanged and excreted slowly in the urine over a period of several days. And hepatic and renal impairment and dialysis have little impact on drug concentration, and therefore no dose adjustment is actually needed in hepatic and renal impairment. Like I said, it is not taken orally. It can be given intravenously or even intrathecal or topical. It is a colloidal suspension, and it's nearly insoluble in water. And because it does not readily pass the blood-brain barrier, let's say you want to give it for cryptococcal meningitis, you give it intrathecal into the subarachnoid space, no, of the CSF. And the half-life is quite long at 15 days. So it's quite toxic. Why is it toxic? Mostly from infusion-related toxicity. It is a suspension. And so nearly universally, when you give it, you may develop some fever, chills, some headache, and vomiting. And this can be ameliorated by giving the drug very slowly or pre-medicating with antipyretics against fever, antihistamines even, or glucocorticoids. When starting therapy, many clinicians administer a small test dose, 1 milligram, to gauge the severity of the reaction, and it serves as a guide as to the initial dosing regimen and the need for pre-medications. Now, the other toxicity is from its cumulative toxicity. While I did say that renal toxicity, or if you have a renal impairment, no, you don't have to dose adjust. As you keep on giving the drug and you already have accumulated cumulative doses of the drug, it can actually cause renal damage. And this is the most significant toxic reaction, and therefore we need to watch the creatinine of the patient. So even if I said that at the beginning, you don't have to dose adjust, even if you have renal impairment, in fact, with successive doses, with chronic dosing, you can develop cumulative toxicity causing renal damage, no? And so some form of renal impairment occurs nearly in all patients treated with clinically significant doses of amphoB, which often stabilizes during therapy, but in the long run can be serious enough to necessitate dialysis. Some elevation of liver function tests can also be seen, like most of the antifungals, as well as anemia. So I've talked about the main prototype of the polyenes, and that's amphotericin B, broadest spectrum of activity against yeast, against molds, um, quite toxic, no? Because of infusion-related toxicity, as well as cumulative toxicity resulting to renal damage, but very useful as the first or initiation therapy for many systemic fungal infections, especially those that are life-threatening. So now I to the next polyene, and that's nystatin. So we are just talking now of the systemic, no, antifungals, but I will just discuss this anyway because this is under the category of the polyenes. So nystatins are actually the first antifungal to be developed and are still in general use. It is not anymore used as a systemic antifungal due to, again, its toxicity, and therefore its main use is topical, no, where it has activity against yeast, such as the Candida species and dermatophytes. And most commonly used in the hospital is actually the nystatin as a gargle, no? You gargle it in your mouth and then you swallow it for the topical treatment of milder forms of oropharyngeal candidiasis. No? And the last one, because it's polyan, amphoB, nystatin, and mycin or pimarisine, it's also given as a topical, typically to treat superficial mycotic infections in the eye. And it's also active against both yeast and molds, no? Much like the amphotericin B. So again, the polyenes are broad spectrum but high toxicity risk, and that's the reason why the nystatin and natamycin are only given topically. Let's take a short break. I just want to show you how beautiful Candida albicans is, no? Showing you its dimorphism. These are the daughter yeast cells. These are the hyphal elements, the pseudo hyphae, and the yeast mother cell. But just to show you its invasiveness of the hyphae in the stratified epithelium of the mouse stomach. No? So it's quite beautiful under the microscope, but it's also quite dangerous in an immunocompromised host. So we've talked about polyenes as the first set of systemic drugs, especially for amphoB, for systemic fungal infections. We'll now go to the next important group of drugs, the azoles, of which there are two main types, the imidazole and the triazole. So for you to remember it, you can say me, dazole. So that's two people, me, dazole, and the triazole, three, which is the newer kinds of your azoles. And the azoles are synthetic compounds which are classified as I said, imidazoles or triazoles according to the number of nitrogen atoms in the 5-membered azole ring. The imidazoles are the older drugs and they comprise ketoconazole, miconazole, and clotrimazole. So again, the prototype, which is ketoconazole. So how do you remember that? Imidazole is followed in the alphabet by J dapat, no? But here, it's followed by K. So, imidazole, ketoconazole, that's the prototype, no? And again, the other kinds of imidazoles, miconazole and clotrimazole, they're actually topical, but I'm just including them here for purposes of discussion. Now, the triazoles, on the other hand, are the newer agents, itraconazole, fluconazole, voriconazole, and posaconazole. So maybe you're wondering, how can I possibly memorize these drugs? My suggestion is just to memorize one kind. If you're going to memorize the imidazoles, just memorize the three that comprise the imidazoles. So whatever remains is a triazole. So in the imidazole will be KMC, no? That will comprise the imidazoles. Keto, mico, and clotrimazole. So keto, mico, and clotrimazole, they comprise the imidazoles. Okay, so what do the azoles do again? No, they again prevent the formation of the ergosterol by inhibiting the fungal cytochrome P450 enzyme. So if you remember the downstream event, this is the last step, no, before it's converted to ergosterol coming from squalene. So the specificity there's a greater affinity for fungal than human cytochrome P450 enzymes, because humans do have this CYP, no, P450 enzymes. And of the two kinds of azoles, it is the newer ones, the triazoles, that have greater specificity. Clinical relevance: the imidazoles are therefore more toxic than the triazoles because of less specificity. Okay, so the imidazoles have less degree of specificity than the triazoles, and this explains their higher incidence of drug interactions and adverse drug reactions. So again, they are in the last step from lanosterol to ergosterol. That's where the azoles work. General uses, no, it's not sidal. So when you're filling up the table in your learning guide, no, while the polyenes, especially amphobi, are fungicidal, the azoles are fungistatic. They work against systemic fungi as well as dermatocytes, and again, they're quite broad spectrum, no? They work against many Candida species, crypto, the endemic mycosis, and in the case of itraconazole and voriconazole, the triazoles, even for aspergillus infections. So if we then map it out, no, in terms of action, again, the mico and keto, as well as the so mainly keto and miconazole, representing the imidazoles, no? You can see that in terms of Candida, the blastococcidio, they are very active, no, even for superficial infections. And for the newer triazoles, represented by fluconazole, for example, no, there is also action against cryptococcal infections, and the same spectrum as even the imidazoles. Take note though that, as like I said, itraconazole has additional action for the aspergillus, no? And fluconazole for cryptococcal meningitis. And what typically happens is that for cryptococcosis, the initiation therapy is typically amphotericin B, and then it can be followed by flucytosine as adjuvant therapy, and fluconazole as completion therapy. So for aspergillosis, you have two options. You can choose the ampho B, or again, it says there, itraconazole can also be a drug of choice for aspergillosis. Now, is there also resistance to azoles? Yes. And there are multiple mechanisms. Resistance is developing because of the increasing use of these agents for prophylaxis and therapy. And this may be due to alteration, no, in the enzymes that are involved in the production of the ergosterol. Or it can be due to the enhanced removal of the azole from the fungal cell. Adverse effects these are relatively non-toxic drug, but again, comparing imidazole to the triazoles are less toxic, and the main toxicity of the imidazoles are actually in the liver. They can cause abnormalities in the liver enzymes and very rarely even clinical hepatitis. And that's why the triazoles have actually, for the most part, replaced the imidazoles, no? Such as the ketoconazole or the miconazole. So the imidazole prototype is ketoconazole, and I think I've shown you already its spectrum of activity. This is a relatively short half-life. It does not enter the CNS well, no, and that's why it's not listed among the choices for cryptococcal meningitis, and mostly fecal excretion after metabolism. Ketoconazole, again, being an imidazole, has a greater propensity to inhibit mammalian cytochrome P450 enzyme, being less selective, and therefore the possibility of hepatic toxicity is greater, and as a result, systemic ketoconazole has actually fallen out of clinical use, and mainly it's used only for its local effects for superficial dermatophytes, no? So ketoconazole used to be available as tablets as well as shampoos and lotions actually for superficial dermatophytic infections. So the imidazole mainly been replaced by the triazoles, especially the prototype fluconazole, and especially fluconazole for cryptococcal infections, and itraconazole, as I've mentioned, for aspergillosis. They become the standard for managing certain forms of systemic mycosis, like I've shown you here, no? Fluconazole again for continuation therapy of crypto, and as itraconazole as the alternative treatment for aspergillosis after amphob. Fluconazole is well absorbed and from the gut, no, and it enters the CNS well, and that's why it can be used for cryptococcal meningitis. Like amphob, it has a relatively long half-life, and some of the adverse effects include non-specific things like headache, nausea, and vomiting. But like the imidazoles, fluconazole can still rarely cause liver injury and liver failure. But drug interactions are less common, less effects on the hepatic microsomal enzymes as compared to the imidazole. And again, its main use is in continuation therapy for cryptococcal meningitis, also for candidiasis and coccidiomycosis. This is, as indicated, the azole of choice in the treatment and secondary prophylaxis of cryptococcal meningitis. And IV fluconazole has equivalent efficacy to amphotericin B in the treatment of candidemia in ICU patients with normal white blood cell count. So you have many choices, no, if you have severe candidemia. It can be amphob, it can be IV fluconazole, but as I will show you later, there is another drug, no, that is now preferred for life-threatening candidemia. Fluconazole is most commonly used for the treatment, though, of mucocutaneous candidiasis, whether it's in the mouth or esophageal area, or in the vaginal area, or in various other parts of the body. So that's fluconazole. and it's active against dimorphic fungi, and in particular for meningitis, no? Okay, but again, there's no activity for aspergillosis, and itraconazole is the better choice for that. Okay. So we've talked about among the triazoles, no, we've talked about the prototype fluconazole. The other drug that's important among the triazoles is itraconazole as a treatment, no, for the dimorphic fungi, histoplasma, blastomycosis, and against the aspergillus species. But it has also been replaced for the most part by voriconazole as the azole of choice for the treatment of aspergillosis. So again, for aspergillosis, yes, you can give amphob, you can give itraconazole, and you may give voriconazole. Okay, so it's used also extensively for superficial infections, dermatophytic in the skin, and even in the nails. Adverse drug reaction is very similar to the other azoles, no? Nausea and vomiting, GI disturbances, and liver dysfunction. And its drug-drug interaction is similar to the other azoles, but to a lesser degree because these are the newer triazoles. The itraconazole is good to use for aspergillosis. It is the azole of choice now for blastomycosis. So you can put that down in your notes. No? For blastomycosis, it's itraconazole. It's available as oral and IV. And absorption is increased by food and low gastric pH. And like the azoles, it interacts with the hepatic microsomal enzyme, and it has some drug interaction when taken with rifamycins, including rifampicin. Like fluconazole, it has a relatively long half-life, metabolized by the liver, but also like ketoconazole, it penetrates poorly into the cerebrospinal fluid, no? And fecal and renal excretion after extensive metabolism. So you always go back, no? What is the azole that has penetration to the CNS? We've talked about so many azoles. It's actually only fluconazole, no? And that's why it's the drug that is given after amphob, after flucytosine, and you continue treatment, you give fluconazole. The rest of the other azoles do not have CNS penetration, only fluconazole. No? So what you try to do is to remember something unique about each of the drugs. No? And for itraconazole, you remember that it can be given for aspergillosis, but it's mainly for blastomycosis. Finally, the last triazole, voriconazole, it's the azole now of choice for aspergillosis, but it has very similar spectrum to itraconazole. Now, there's one last azole, one of the newest azoles, posaconazole. It's also indicated actually for a broad variety of systemic fungal infections like invasive candidiasis, aspergillosis, and it's only orally available, but it's actually not yet listed in the WHO essential medicines list. So again, we go back and remember important highlights for each of them. So among the imidazoles, ketoconazole is actually the prototype. It has action against blastococcidio and histoplasmosis and candidiasis. But because of the toxicity that's typically expected with the imidazoles, they have been mostly delegated to the treatment of superficial infections whether dermatophytic or superficial mucocutaneous candidiasis. On the other hand, itraconazole has a spectrum that is quite similar to fluconazole, except that fluconazole is unique because it's the continuation drug after amphoB and flucytosine. So fluconazole is for cryptococcal meningitis. Itraconazole, the highlight is that it's the drug of choice for blastomycosis, and voriconazole is now considered to be the drug of choice for aspergillosis. So we've talked about the polyenes, talked about the azoles, the imidazoles, and the triazoles. Now we'll talk about the anti-metabolites, fluorocytosine or flucytosine, or 5-FC shorthand. And this drug was discovered in 1957 during a search for novel anti-neoplastic agents. And it's devoid of anti-cancer properties, but they discovered that it's a potent antifungal agent. And it's related to the chemotherapeutic agent 5-FU, and in fact, it's converted inside the body to 5-FU. The spectrum of action is much narrower than that of amphotericin B. And if we talk about its mechanism of action, like I said, it's taken up by the fungal cells via the enzyme cytosine permease, and it's converted intracellularly first to 5-FU and then to 5-FDUMP and fluoridine triphosphate, both of which inhibit DNA and RNA synthesis respectively. Human cells are unable to convert the parent drug to its active metabolite. So all of this happen within the fungal cell. So again, just to show you, the flucytosine is outside the fungal cell. It's allowed to enter through the permease enzyme, where now it is converted to 5-FU, which is subsequently converted to 5-DUMP and 5-FUTP, which inhibit both DNA and RNA synthesis. Flucytosine, though, is not typically used for monotherapy. It is used synergistically with amphoB, and this may be related to the enhanced penetration of flucytosine through the amphotericin-damaged fungal cell membrane. So if it has to go inside the nucleus, it's hard for this drug to do that. But if you now have amphotericin B, which creates these spores, then the uptake of this drug will be better through the amphotericin-damaged fungal cell membranes. In vitro, synergy is also seen with the azole drugs, because the azole drugs are also important in that they permit the breakdown of the cell membrane. The mechanism of resistance is through altered metabolism of flucytosine, but it's quite uncommon. But it develops when it is used in monotherapy, and that's why flucytosine is unique, because it's typically used synergistically with another drug. Given orally, it's well absorbed. This is the third drug that has penetration to the CNS. So again, first is the amphotericin B does not have penetration, so it's given intrathecally. Fluconazole has penetration, and this is the third drug, flucytosine. So remember, diba, you give amphoB first intrathecally, then you give flucytosine along with the amphoB synergistically, and then in the continuation phase, you give fluconazole. So these are the drugs that are important in cryptococcal infections. Okay, toxicity is very similar to amphotericin B, in that because it's excreted and changed in the urine, the metabolites may accumulate in the renal tubules, leading to toxicity. Now, the uses, again, I've already talked about this, cryptococcal infections, all C, no? Candida and chromoblastomycosis. And it's also fungistatic, no? Now, here again is how it's used, typically combined with amphoby for cryptococcal meningitis or with itraconazole for chromoblastomycosis or for blastomycosis. Okay, so just to reiterate that it is used in combination therapy. And so here highlighted in this table is its main use in crypto combined with amphoby and even actually for chromoblastomycosis combined with itraconazole. Toxicity will be mainly from metabolism to the toxic antineoplastic compound 5-FU, no? And so in cumulative doses, it may actually cause bone marrow toxicity with anemia, leukopenia, and thrombocytopenia, and less frequently, liver enzyme elevation. So, we've talked about amphoby, we've talked about the imidazoles and the triazoles, we've talked about the anti-metabolite fucytosine. Let's talk about the echinocandins. The echinocandins are easy to remember because they all end in fungin. Caspofungin, micafungin, nidolafungin, no? And although they're not yet in the WHO essential medicines list, important set of drugs because they're also fungicidal, no? And these echinocandins act at the level of the fungal cell wall by inhibiting the synthesis of the beta-1,3-glucan, resulting in disruption of the fungal cell wall and cell death. So they're cidal. No? So just to show you again the action of the echinocandins. And these are the newest class to be developed. That's their structure, no? And they're active against both Candida and Aspergillus. And they're actually now, the echinocandins are actually now the preferred, rather than fluconazole, they're actually now preferred as the treatment for serious candidal infections, no? Among those who are seriously ill, even in the intensive care units, no? So mainly they're used for serious candidemia, especially in the ICU. They're available only in intravenous forms. All are water soluble and highly protein bound, and the metabolites are excreted by the kidney and the GI tract. Dosage adjustments are required only for severe hepatic insufficiency. And among the three, it is the last, anidolafungin, that has a very long half-life. Adverse effects, they're actually well tolerated with just some minor flushing reported and some elevation in those receiving caspofungin only when combined with cyclosporine. And so if we go to the clinical uses of these drugs, like I said, they're now given for disseminated and mucocutaneous candida as empiric therapy, no, during febrile neutropenia, no, rather than giving fluconazole. If you want something that is more potent, that is relatively safer, this is typically the drug of choice. And even in invasive aspergillosis as salvage therapy after they have failed to respond to other drugs. Micafungin is also licensed for mucocutaneous candidiasis and anidolafungin for also esophageal candidiasis and invasive candidiasis, including septicemia. So there's a whole lot of words. Just remember that the echinocandins, the C there, represent candida. Diba? So echinocandins. They're a lot used now for serious candidal infections especially among those with febrile neutropenia and those who develop candidemia in the intensive care. No? Okay, so we are done with the first set of antifungals, which are systemic antifungals for systemic infections. For the most part, all of those drugs that we've talked about, the polines, no, the azoles, the echinocandins, they can actually also be given for mucocutaneous infections. And so that entire list that we talked about can also be included under this list. But we now include also griseofulvin and allylamine. The next or the first drug is griseofulvin, which is fungistatic and is derived from a species of Penicillium. It is used only in the systemic treatment of dermatophytosis and is orally administered in a microcrystalline form. The mechanism of action is at the cellular level is unclear, but it is deposited in newly forming skin where it binds to keratin, protecting new skin from infection. And the theory is that it binds to microtubules comprising the spindles and inhibits mitosis. No? Since the action is to prevent infection of new structures, it must be administered continuously for 2 to 6 weeks in skin and hair infections to allow the replacement of the infected keratin by resistant structures. And so nail infections may require therapy for months using this drug to allow regrowth of new protected nail and is often followed by relapse. No? Since then, it has been replaced actually largely by newer antifungal medications such as itraconazole or even terbinafine actually. No? So griseofulvin orally, not topically. It's metabolized and renally excreted, and several weeks of therapy are needed. And in terms of ADRs, no? Again, top of the list is both hepatotoxicity and renal toxicity. So imagine having to treat only superficial mucocutaneous infection, fungal infections, no, with a systemic drug, and then you will encounter this toxicity. And that's why, like I said, they've been essentially actually replaced by the newer azoles. So just to show you, the griseofulvin, no, not a lot of systemic use. It's really for superficial infections, typically dermatophytic. Now we last few drugs, no, the allylamines, and its prototype is terbinafine. It's topical, and it's like griseofulvin, it's a keratophilic medication, but it's not. It is fungicidal though, no. So it is a lot more effective as compared to griseofulvin, which is static. So it interferes with ergosterol, but at an earlier phase, no, of the production of ergosterol. And so this interference, no, with the action of the enzyme squalene epoxidase, this leads to the accumulation of the sterol squalene, which is toxic to the organism. It is then metabolized and excreted in the urine, and it's a very safe drug, no? Very rare adverse drug reaction. Show you the action of the allylamine. It accumulates squalene and 2,3-oxide, which apparently is toxic to the cell. Now, prototype terbinafine, its clinical use is that one tablet given daily for 12 weeks achieves a cure rate of 90% for nail infections and is more effective than both the static glycofulvin or even itraconazole. The adverse effects are rare and doesn't seem to typically affect the cytochrome P450 system with no significant drug interactions. We've gone through the systemic antifungals for systemic infections. We've talked about systemic antifungals for mucocutaneous infection. So we'll now go into the topical antifungal therapies. And for the most part, we've talked about them. No? Nystatin as an example of the polyenes, the topical azoles like ketoconazole or itraconazole, or even topical allylamines. No? Some side notes, no? I've talked about nystatin. It's available as creams, ointments, suppositories, gargles, no? And it's in the skin, it's not significantly absorbed, nor in the mucous membranes or the GI tract, and therefore use topically has little toxicity, although oral use is often limited because of its unpleasant taste. Quite active against most of the candidal species, and it's used for the suppression of local candidal infections like oropharyngeal thrush, vaginal candidiasis, and even intertriginous candidal infections in the skin. Examples of topical azoles like clotrimazole, so that must be familiar to you, canesten, miconazole, and even topical ketoconazole as shampoos, for example. So they're often available as over-the-counter drugs, especially for vulvovaginal candidiasis. Remember Chris Aquino, no? Even as treatment of oral thrush. And it's much better tasting as compared to nystatin, but I don't think we have this in the Philippines. In cream or ointment form, both agents are useful for dermatophytic infections like tinea corporis, tinea pedis, and even tinea cruris. And there is little absorption in the skin, and adverse effects are rare. Again, don't memorize this, please. Just to give you the longer list of other topical azoles that are actually available internationally. I've just highlighted the two that are available in the Philippines, no? And even for shampoo form of ketoconazole, they're typically for seborrheic dermatitis and fungal infections in the scalp. There are also topical allylamines, like I said, that are important for dermatophytic infections. So just to round up, there are other actually antifungals whose mechanism of action are different. No? So for example, saturated solution of potassium iodide can be given for cutaneous infections, no? Such as sporotrichosis, and they act by enhancing the transepidermal elimination process in the epidermal in the infected host. But they may cause some rash and irritation of the salivary and lacrimal glands. No? So just be careful in administering them. Other drugs are cyclopirox, olamine, that blocks the amino acid transport. Remember, I said that in the fungal cell wall, it's also made up of proteins, no? Along with the beta glucans. So this is the drug that inhibits that or that blocks that amino acid transport. Or even tolnaftate for dermatophytes that inhibits the synthesis of important macromolecules. So I've included this whole list of drugs just for completion. Aside from tolnaftate, no, and the saturated solution of potassium iodide, I don't think that any of these drugs are actually available locally. And just to show you again the spectrum of activity of the drugs. In guide, I have asked you to fill up the form, no, in order to just list down which are the cidal drugs and which are the static drugs, no. And an ideal antifungal has good selectivity in that it will eliminate the fungal pathogen, but will actually render minimal toxicity to the host. That's the ideal antifungal. And in choosing antifungals, it's very different, no, from choosing antibacterials. In vitro susceptibility testing with the fungi is not yet standardized. And the result of in vitro tests don't always compare to the results obtained in vivo. And therefore, what is typically done is to primarily select an antifungal for clinical use, primarily on the basis of the specific pathogen, fungal pathogen, that is isolated or that is suspected. And we use the spectrum of activity for the licensed antifungal to guide our therapy, no? Rather than the in vitro susceptibility testing. Challenges in the treatment of fungal infections involve, of course, like I said, the development of resistance, the treatment of life-threatening systemic mycosis in the immunocompromised patient, no, especially after cancer chemotherapy, where sometimes we are just guessing, no, at the most possible pathogen. It's typically candidemia, and so we want to give them cidal drugs whenever possible. And the search continues for fungicidal agents that are non-toxic to the host, and research towards immunomodulating agents, no, that can actually just reverse the defects of native host immunity, allowing our own innate, no, uh, protective ability, or our own innate immunity to be able to counteract the fungal infection. So, thank you. We've talked about the full list, no, full spectrum of all of different antifungals. There's still a table after this times up clock. You may just browse through it, but actually the discussion, especially the table where we specify the spectrum of activity of the drug, as well as the specifications as to whether they're cidal or static, and their mechanism of action is are the most important things to remember for this particular lecture. So thank you very much for your time and attention.